So, ladies and gentlemen, welcome to the grand finale of the Endoscopy Premier League. We have been waiting for this grand finale for a long time. This has been such a wonderful and a beautiful journey, so well appreciated by our audience, and TOG and Science Integra and Sun Inca has made this finally to you. So we are going to go live from Indonesia and Malaysia, and I call upon my umpires. We have been such a wonderful umpires today, and the panelists with their sharp cuts and wristy shots have been so loved and appreciated that we will come back with season 2 soon post this mega finale. We are live now, and I call upon my two great friends and my colleagues and seniors, none other than Dr. Narendra Malhotra, Professor Dobrovenik International University, the King of Agra, President of ISPAT, Isar Safog, Foxy, Dean ICMU, and lots many more. And I welcome Professor Dr. P K Shah. He is from KM Hospital, past Dean, ICMU, IAG, President Foxy, MOGS, IFUMB, and a great teacher of teachers. I thank them to be the wonderful, wonderful, great umpires today. And we have got wonderful people from Southeast Asia, and I welcome my best friend, Ichnandy Arief Rachman from Indonesia, and he's going to talk today on vaginal myomectomy. And I have my another great friend from Malaysia, that's Dr. Sevellaraja Supermaniam. I can call him a Superman. And we have the same test of walking and running. He's a past president of Apache, past president of Malaysia Society, and I'm going to have them live. He's going to talk on HIFU, on fibroids. So our panelists are so well read and so heavily followed that today's match is going to be a scientific delight to hear. I hand over the mic to Dr. Narendra Malhotra and Dr. P K Shah to start this match. Thank you.
So good evening, ladies and gentlemen. It's indeed a pleasure to welcome you all to this grand finale of the EPL. We've had a fantastic season, and you've seen 2 matches being played every week, and it's been very, very exciting with such great players talking about everything in endoscopy. Today, we are going to tackle a very, very important disease which women have, fibroids. And we still do not know how to deal with fibroids. A lot of us will operate, and we'll operate open the whole abdomen, and then we come again, and then we operate all over again. A lot of us do heroic myomectomies to be in the Guinness Book of Records, and a lot of us do embolization now, and we are now seeing HIFU, which is a new technology which has come in, which could be MRI guided or even better ultrasound guided also. So we have 2 excellent, excellent people who will be talking to us. Rachman on vaginal myomectomy and Sevellaraja on HIFU. The toss has been won by Rachman, and I would now request and invite him to come and deliberate. Oh, sorry. So they have 15 minutes each to present their topic, and then they will get 2 to 3 minutes as a rejoinder to counteract on the arguments made by the other. And then, of course, expert comments from Professor P K Shah, myself, and Dr. Niranjan Chavan. And then we have the public voting. So for those who are listening to this audience, please be ready for voting. You would prefer to vote for vaginal myomectomy, or you would prefer to vote for HIFU? That is the question. Vaginal myomectomy or HIFU? I know very less of us are doing all this in India, but then we will be soon doing all this. So you still have to vote on what you like. And over to Dr. Niranjan to start the match.
Thank you, sir, for that wonderful introduction. And I want to tell all of you that there are 745, that is 745 doctors live with us right now, and it's going to be a wonderful match. I hand over the mic to Dr. Narendra Malhotra. Please go ahead, sir.
So we've had the toss and it is won by Rachman, and Rachman will be talking to us on vaginal myomectomy. Let's see, your time starts now. You can share your screen and you have 15 minutes. At 14 minutes, I will warn you 1 minute left and we will stop you at 15.
Okay. Thank you so much, Dr. Narendra Malhotra. Thank you so much, Dr. Niranjan. Hello, everybody. My name is Nandi from Indonesia. And then I have a topic about how to encourage you all to perform the vaginal myomectomy. So, for you who doesn't know the history, the original myomectomy was performed in 1840s by Attlee and Amusat through the vaginal surgery. So, and then in 1994, by Adam Magos, he reported the first modern vaginal myomectomy in 1994. So Adam Magos is a teacher of our friend, the late Rakesh Sinha, and then both of them are together reporting the case that they're supposed to do it with laparoscopy, but since the myoma is very far away in the cervical part, they decided to switch the laparoscopy myomectomy into the vaginal myomectomy. But it's not until 2006 when Roberto Carminati and friends from Italy, they are issuing the anterior and posterior vaginal myomectomy, which is the new surgical technique. And then, so we go directly into vaginal myomectomy. This is, I get the picture from the Roberto report. You know, there are two axes, the anterior axis and the posterior axis. And then you should decide which axis that you want to use regarding the position and the size of the myoma. So in here, I would like to show you when we choose the anterior axis, when you want to take the myoma from the anterior part of the uterus. So as you can see here, you should skeletonizing the cervix and then go in safely and then separating the bladder pillar on the side and then go safely inside. Afterward, you take out the myoma, take in by tenaculum. It was so easy. And then you can suture it from below. And then the procedure is done. And then you close up the anterior colpotomy, and then this is the final result. But then we all should know that the vaginal route itself has been used by the endoscopic procedure since 1901. And then it was started as ventroscopy and then continue into colpolaparoscopy, kudoscopy, and then in 1978 by Diamond, there was a diagnostic kudoscopy. And then our good friend Stefan Gortz inventing the transvaginal hydrolaparoscopy, transvaginal endoscopy, along with Antoine Waterloo, which is until now, the TVE and the fertiloscopy is the only vaginal nodes in the that could be done in the office setting. And then in the gynecologist itself, it was the Changgang team under the leader of the Professor Lee, who performed the first transvaginal nodes in an Excel procedure. They performed 3 tubal sterilization, 3 salpingectomy, and then 4 ovarian tumor enucleation from May 2010 up to June 2011. And then Lee and friends also performed the transvaginal node hysterectomy from May 10, 2010 to August 2011. And then the first time they published about the transvaginal nodes myomectomy, it was in 2014. And then they even can go further with the transvaginal node surgical staging. So the transvaginal node, since this is an EPL Endoscopic Premier League. So I'm going to focus on transvaginal nodes. Transvaginal nodes is a marriage between vaginal procedure and a single port laparoscopy. So by incorporating the advantage of the endoscopic surgery, vaginal nodes broadens the indication for vaginal procedures and help overcome its limitation. At the same time, the vaginal nodes approach will avoid the abdominal wall wounds and trocar-related complication while giving more ergonomic position for the surgeon. So the thing, if you already perform a laparoscopy and if you already perform a vaginal surgery, you don't need any extra expensive device to start to perform the transvaginal nodes. All you need is a wound retractor. This is some of the commercialized platforms that are marketing in the world, and the one that I bought is the one that extensively used in Indonesia and marketing in Indonesia. The other one is either too expensive or we just cannot afford it. So this is the wound retractor, and this is the single port that I use in my center. This is what we call the Nellis port. So I'm going to show you an animation how to perform hysterectomy nodes, because the first thing when you want to try out transvaginal myomectomy, you should be able to perform transvaginal nodes. So as you can see here, this is the vagina, the cervix, and the uterus. So when you perform transvaginal hysterectomy nodes, you have two phases, the vaginal phase and the endoscopic phase. So the thing is, you just skeletonizing the cervix like the way that our senior did it during the vaginal hysterectomy, and then after you putting it, you can take out the uterus easily. And now, if you already able to perform this, you can expand yourself, move forward into a myomectomy. So in this slide, I will show you if we have a myoma in the anterior side of the uterus. So what we do is, if in hysterectomy, we skeletonizing the cervix, doing both colpotomy anterior and posterior, if we take out myoma, we just choose which side that we are going to take. So like the one that stated in Magos, we can choose our anterior access or posterior access. And then it's all the same vaginal phase, but the thing is we need to put our wound retractor in the anterior access and then continue with the endoscopic phase. We can take out the myoma. And then, of course, some of you may be wondering what will happen if we take out the myoma. How can we suture it? The thing is, if you are able to perform laparoscopic suturing ipsilateral, it will be very easy for you to perform suturing in vaginal nodes. It's even better because your position is very ergonomic. You are sitting down comfortably like what I do now, like Dr. Narendra sitting comfortably. And then we just do like this. It's like in karaoke, but instead of singing, we are moving our hand forward, just like the way we do ipsilateral. And then the myoma is done. Okay, and then what happens if we have a posterior myoma? So if we have the posterior myoma, then of course you need to move your wound retractor to the posterior side. Of course, there is still a learning curve you should be able to diagnose the myoma position, and then you should be sure that there's no adhesion on the posterior part, then you are safe to go. And then afterward, it's just another endoscopic phase. Take out the myoma, do the suturing, and it's all finished. So in here, I will show you how to skeletonizing the cervix. The thing is, I'm not a urogyne, so I'm not really familiar at first with the vaginal procedure. I know that most of my Indian friends are very capable vaginal surgeon, because I know Professor Purandare is come from India, right? He has a very good technique. And then the thing is, what you need to do when you put skeletonizing the cervix for the first time, you should avoid the bladder pillar, which is lies on the 11 and 1 o'clock position. And then you just dissecting it with scissors. Then you are sure that you are skeletonizing it safely and bleedless. Because the thing is, when me and Dr. Salfa starting to do the transvaginal notes, if we have bleeders from the very first step, it will discourage us to go further. So this is the key point, that you need to avoid the bladder pillar, especially if you want to use the anterior access. Then afterward, because the one that I'm showing you is the transvaginal hysterectomy, but the same principle is applied. So you just squeeze in the wound retractor like so, and then push away with your long finger, with your index finger. And then if your finger is not long enough, I'm using my middle finger like so, just to position the wound retractor in the right place. So for the upper side, you should put it behind the symphysis, and then the wound retractor will lie comfortably and then not moving at all. And then afterward, you just move, folding forward the second ring towards the vagina, and then make sure the position of the wound retractor is firm and settled. Okay. And then one of the key is to put in a gauze. You see, why gauze? In any transvaginal nodes procedure you perform, either even it's hysterectomy, even it's myomectomy or cystectomy, the gauze will help you to put away the column. Yes, so it will clear up your view, and then everything will be nice. And then next is you need to apply the port. Then if you apply the port, then you are ready to go. Remember, your position is like our position right now. You are sitting down comfortably, and then you just start to play. So in the next video, this is from our friend, Professor Juan Liu from Guangzhou. She's a urogynecologist. So in this part, she performed a 6 centimeter myomectomy in the anterior part. And then if you need to perform suturing in the transvaginal routes, it will be better if you use the barb threads, because the barb threads will able to give you the certain traction that you need without any need for a further instrument. And then it is done. And then you can morcellate the myoma within the wound retractor, and then it finishes. As you can see, this is the wound retractor lies beneath the upper side of the uterus, and then the upper part is lies beneath the symphysis, and then you are good to go to perform anterior myomectomy. So I came up to the later part of my presentation. So why vaginal node myomectomy? First one is good for the patient. It has no scar. So because all our patient is a lady, and a lady would appreciate if there are no scar at all. And then, not to mention the benefit, if you combining the vaginal surgery with the single port surgery, is very beneficial for the patient, and then also broaden the limitation if you only perform it in the vaginal surgery way. And then the best part for us is ergonomic. This is very ergonomic, very natural position for us. It is easy for us, and then easy for our back, easy for our shoulder. Is very nice for the surgeon. And the good thing is you do not need special extra equipment. All you need, yes, doctor, all you need is your skills and a wound retractor. If you don't have a single port device, it's okay. You just use the wound retractor, and then you put a hand screw over the wound retractor, and then you are good to go. So it's more benefit, it's cost benefit, no scar, more ergonomic, and no need to any expensive equipment. I'm smiling at Dr. Selva right now. So I hope and I encourage you all to perform the vaginal nodes, and then if you are fine with it, and then go to vaginal nodes myomectomy. And then, of course, as part of the nodes group, we have a page in the Facebook where you can learn this part. Me and Dr. Selva is also part of the group. So from Indonesia, from Jakarta, from the Gatot Subroto Army Hospital, the Presidential Hospital, I would like to say thank you. And then vote for vaginal nodes myomectomy. Thank you. Thank you.
So fantastic.
Thank you, Dr. Narendra.
Well done. No scar, and you got rid of the fibroids, and you've sutured it also. Expert
Yes.
comments, PK. 1 minute, one comment, and then we go to the other one.
Hi. Sorry, I joined slightly late.
Hi, Dr.
In the other
PK.
webinar. Nice to see you.
Yeah,
And it was amazing. But I will not make any comment right now.
Then, yeah.
Because I'm the umpire. And both Narendra and myself, we are umpires. So we will wait for the second talk to be over. And then we will see how rebuttal goes. And then we will have our comments.
Yes.
So I have a great pleasure to invite. You want to say anything, Naren?
Yeah, after you say, then after you invite him.
I think it is great to see somebody from Indonesia talking to us on webinar. I think I have heard you for the first time on webinar, and I am impressed. So we will have even one more gentleman from Malaysia, Dr. Sevellaraja Supermaniam.
He's a very good surgeon.
So today we have two super people who are going to talk to us on something which probably we should follow. So it's a great pleasure to have you here from Malaysia. And which part of Malaysia, sir, you belong to?
I'm from Malacca, Malaysia.
Malacca. Okay. Great. So Naren, you have the introduction slide.
So introduction has been given. So
Okay.
Selva, Dr. Selva, Malacca, we were there 3 years back. We brought a whole big tour, and we were there at your college. So our friend Nandi says myomectomy is like singing karaoke with a mic. And he says, just open the vagina, put in the scopes, take it out, suture it. That's it. No scar, nothing. And he's sitting and doing it. So we would like to hear from you why even you should cut. You can do it from far away. So let's hear what Selva has to say.
Yeah.
Let me share my screen.
Yes, please. 15 minutes, your time will start as soon as your screen comes.
Can you see my slide?
Yes, we can.
Oh, yes.
Okay. Firstly, let me thank the organizers, Dr. Chavan, Dr. Malhotra, and Dr. P K Shah for inviting me to speak on this new topic. It is called HIFU. So this is a debate. So what I intend to do is first part of my talk, I will just give some information about HIFU. I think many people might have heard about it, but don't know exactly what it is. So I will give a lot of information about HIFU and a little bit, I will give a rebuttal to what Dr. Nandi has spoken because this is a debate. So I hope I can clear everything within 15 minutes. Okay, my first slide is what is HIFU? Now, HIFU stands for high intensity focused ultrasound. Now, basically, we are using ultrasound beam. We focus it onto a fibroid or adenomyosis and destroying the tissue, causing them to shrink. So the principle is here. High intensity ultrasound waves are focused onto a focal spot by the HIFU transducer. This is the HIFU transducer. We focus the spot, and the spot is called a biological focal region. It's actually the size of a grain of rice. And that spot is heated up, and it will cause destruction, cause cavitation, heating, coagulation. So the temperature goes up between about 75 to 100 degrees, and this will cause necrosis and death of the tissue that we are ablating. In this case, a fibroid. Now, you might have heard of HIFU, which is not very good because HIFU actually has got two modalities. One is called the MRI-based HIFU, and the second is called ultrasound-based HIFU. The principle of HIFU is the same. That means we are using high-intensity focused ultrasound, but the modality of imaging is different. One is using MRI, and the other one is using ultrasound. So I'll explain to you all what is the two differences in a little while. So basically, when we do HIFU, this is how it is done. As I said, one focus would be one grain of rice, and then we join the grain of rice to become a line, and then we join the lines to become a volume, and then ultimately it becomes a volume. So the fibroid is just sliced into different areas, and it is coagulated slice by slice until we get the whole fibroid, we kill off the whole fibroid, and that is how it is done. And this is another video showing what happens is you can see that you can see an ablation. Usually there's a grayscale, there's a whitening of the area, and then you go to another spot and it becomes white, and then you go to another spot, it becomes white again, and this is how we know that the area is being coagulated. So this is how HIFU works. And here is another spot, and so by looking at the grayscale, we will know that the HIFU has been the tissue has been ablated. Okay, let me show you all this little video. Second, okay, this video. Now this video shows the safety features of HIFU. You can see that this is the transducer. It is actually causing burns on this plate, but when you put your hand across, there's no burns at all. So it's very safe procedure. Only the area where is being ablated will get that effect. And here you can see what is being done is that this word, this stands for China in Mandarin, Chongguo, and they are writing this, they're burning this area into an ox liver. So this exercise shows the precision of this machine, which is precise to burn these lines in the ox liver. So this ox liver, there is burn inside and is being sliced, and this will show you how precise this machine is to ablate this line into this ox liver. So this will give you an idea of how this technology works. Now, as I told earlier, my job is to tell you all the difference between MRI-based HIFU and ultrasound-based HIFU. As I said earlier, the HIFU itself is the same, but the technology to visualize the fibroid or the uterus is different. So the advantages of an MRI-based HIFU is that it has got very good anatomical resolution. We know that MRI will give you a good image compared to ultrasound. That there is temperature monitoring with MRI-based HIFU. However, the advantages of an ultrasound-based HIFU is that, as you can see, the transducers can move much better here than in this hollow area. And also the patient positioning is also very comfortable here. Patients are very comfortable. It's an open concept, whereas here is a hollow. Patient gets claustrophobic. And there's a lot of noise with the MRI-based HIFU. But what is a big advantage is that the treatment time, because the transducers are bigger and you can position the patient better, you can do the procedures much faster than in an MRI-based HIFU. So it can be done within 1 to 2 hours, whereas in an MRI-based HIFU, it takes 3 to 4 hours. What is more important is the efficacy, what we call as a non-perfusion volume ratio, is much lesser in MRI-based HIFU than ultrasound-based HIFU. And that's the reason why MRI-based HIFU never actually took off. It has been around for nearly 15 years, but it never got took off. Another important factor is that anybody who does ultrasound can do an ultrasound-based HIFU, as opposed to MRI-based HIFU is only be done by an interventional radiologist. So any gynecologist, any ultrasound sonographer who has got a very good spatial ability to look at the uterus, you can do an ultrasound-based HIFU. So what are the advantages of this? The advantages of this is that it is a non-invasive treatment to preserve the organs. The whole concept of using HIFU is not to remove the uterus, to try and preserve the uterus. Of course, it is also got the advantage of no blood transfusion, no radiation, and there is no incision on the abdomen. And it is a daycare procedure, and the patient can get back to work very quickly. In fact, they can get back to work in 1 to 2 days. And the other advantage is that it is very precise, and the ablation is very precise, and it does not require general anesthesia. It's done only under sedation, and it is very comfortable and relaxed for the patient, and it's got very few complications. I will talk about complications a little while. So these are the big advantages. So the big advantages here, as opposed to what Nandi says, of course, Dr. Nandi, the vaginal myomectomy, there is no incision on the abdomen, but still there is an incision in the vagina. But more importantly, there is an incision on the uterus, whereas here, there are no incisions on the abdomen or the uterus. So that is a big advantage of this kind of ablative therapy. Now, you might ask me, why is it not known so far? Now, this technology, the one I'm discussing, ultrasound-based HIFU, is pioneered by China. It's in a place called Chongqing, China. And so far, they have brought it to many countries in the world. It is available in many centers in United Kingdom, for example, Oxford, in Germany, in Bulgaria, in South Africa, in South America, and also now in Southeast Asia. And now only they are coming out and promoting it in a big manner. And it is available in more than probably about 300 centers in Asia, 10 centers, more than 10 centers in Europe, and almost 150,000 patients have been treated with this HIFU treatment using this particular model, which is the Chongqing HIFU machine. Now, there are many publications on this HIFU, especially by this company, HIFU company, and 52% of the literature on HIFU is by Chongqing HIFU machine. And there are many publications. I have no time to talk about all the publications. My job is to convince you that this is a good machine, that it will benefit patients who have fibroids. And this is one of the earlier papers that has been published. It is published, this is between 2006 and 2009, 757 patients were treated with this number of fibroids in this university, in Chongqing Medical University in China. And out of the 757 patients, 293 are submucous fibroid, 668 intramural fibroids, and 153 are subserosal fibroids. And the non-perfusion ratio is 84%. That is how good this particular machine is. And you can see that as you know, in HIFU, unlike myomectomy, you take out the whole fibroid and then you suture the uterus. Whereas in HIFU, we are not removing anything. We're just ablating and waiting for it to die. And it takes time for it to shrink. So this is the level of shrinkage. At 3 months, there's 31% shrinkage. At 6 months, there's 58% shrinkage. 12 months, 70%. 24 months, 82%. And 36 months, 89%. So there will be some residual tumor in the uterus, but in almost 90% of the patient, it will shrink to a small number. As far as the symptoms is concerned, there is, after 36 months, 92% will have symptom improvement. So that is a big benefit of using HIFU for fibroids. Now, what about complications? Now, this is a study that showed 10,000 patients who have undergone ultrasound-based ablation for fibroids and adenomyosis, and these are the complication rates. The complications are 10%, but most of the complication, which is serious complications, is only 1.8%, and the most serious complication is actually 0.46%. The most serious complication, and the most serious complication is intestinal perforation. If you use HIFU and there is a bowel along the way, then you can perforate the bowel, and it is only 2 in 10,000. So we can't even give this kind of figure for any kind of myomectomies, open, vaginal, or laparoscopic myomectomy. The other complications are very minor complications like vaginal secretions, lower abdominal pain, buttock pains, hematuria, uterine bleeding, blurred visions. One of the complications that we worry about is skin burns, especially in patients with previous operations. If they have multiple scars, these scars can absorb the ultrasound and can cause burns, and these burns can be quite serious. So whenever a patient has got scars, we have to do it very carefully. This procedure is done in the prone position. I didn't have time to show you that photograph, and the patient actually will be lying on a bowl of ice cold water so that it will cool down this skin when the ablation is done. So what about fertility? Now, one of the problems of, especially in uterine artery embolization, is that you have decrease in what we call as AMH. There is a possibility that the ovarian function will be affected. This study shows that HIFU does not have any effect on AMH. So what they did is they took these patients and did the AMH first, and then ablated the fibroids, and then repeated the AMH, and they found that ultrasound-based HIFU ablation of uterine fibroid and adenomyosis was effective without affecting ovarian reserve. So we can safely use in patients who are keen to get pregnant. Another issue is pregnancy outcome. This is an area of my interest as well. So we know that if you do myomectomy, any type of myomectomy, open myomectomy, laparoscopic myomectomy, vaginal myomectomies, you're going to have an incision on the uterus. And there's always a worry of uterine rupture. It is not common, it's rare. I've actually reviewed this, but it's still a possibility. Here in this particular study, there are 71 live births after 78 patients who have undergone HIFU, and none of them had any risk of any obstetric results, no uterine rupture, and the patients, most of them had normal vaginal delivery. So it is a very safe procedure and very little obstetric risk. So this is the advantage of HIFU. HIFU does not cause an incision on the uterus, and the uterus is ablated and it shrinks. So that is a difference between HIFU and myomectomy. So this is my area of interest, which is intramural fibroid and fertility, to operate or not. I did a review article, I wrote a review article, and my interest is that small fibroids which are less than 5 centimeters, basically 3 to 5 centimeters. Most of us IVF specialists would not want to operate on these fibroids, especially if they are intramural. If they are submucous, of course, we have to remove them. But if they are intramural, non-cavity distorting, they are not done. And we just do the IVF, we just try to get them pregnant. But in this review article, I showed clearly that presence of this fibroid actually decreases pregnancy rates. Although we get a lot of patients pregnant, but the pregnancy rates is actually lesser. So to do a myomectomy on this kind of patients with small fibroids is cruel. I mean, it's not nice to go and do a myomectomy just to remove a 3 centimeter fibroid. After reviewing all the different techniques available, including ESMAIA, UAE, I realized that the best way to treat this kind of fibroid will be by ablating, especially using HIFU. So this will be my area of interest and my area of studies to see whether pregnancy will be improved by ablating these small fibroids and seeing whether the patients can achieve a pregnancy spontaneously as well as by IVF. So finally, let me do a little bit of rebuttal to Dr. Nandi's presentation. He presented very well. Now, myomectomy itself is not a difficult surgery, but a tedious surgery, even laparoscopic myomectomy. But to do it by vaginal method, it is not going to be very easy. I have done quite a number of vaginal V nodes, hysterectomies and cystectomies. I have not done myomectomies yet, but I think it's not an easy surgery. The access ports are small. You know that you are going into the anterior pouch of Douglas, anterior fornix, and you're going into the pouch of Douglas. The area is small, and how many fibroids can you remove from this area? Vision is not very good. I mean, Dr. Nandi showed very nice videos, but I can assure you it is a very narrow area to try and look and remove all the fibroids that you want to remove. So, and also you can probably do a limited number of fibroids from this area. Again, suturing, Dr. Liu showed that she showed the suturing, but suppose you have a very large intramural fibroid and you want to try and do it by vaginal myomectomy, to suture it in 2 or 3 layers is not easy. I have done this. I have tried this by single port. It's not easy. And although vaginal, you have more space to do, but suturing in 3 different layers is not going to be very easy. Finally, it's also going to be very difficult to do repeated surgery when there is additions. So it's a novel method doing vaginal myomectomy, but I think its usage is quite limited. So I have to go in a debate manner, Dr. Nandi. So I have to say that if you want to compare the benefits of HIFU compared to vaginal myomectomy, I'm sure you will agree that HIFU will be a far better way to treat these fibroids than doing vaginal myomectomy.
1 minute.
So that is my talk. I'll pass it back to you, Dr. Malhotra and Dr. P K Shah.
Thank you. Thank you very much. Thank you very much, Dr. Nandi. He says a lot of things, and you have 2 minutes to rebut what he says.
Thank you, Dr. Narendra. So after seeing Salfa, I do have some agreement with him, but some disagreement with him. But one thing for sure, that vaginal node myomectomy can be learned. It is need a learning curve, but it can be learned. And then the good thing for us Asian is not going to cost us so much. Yeah, what Dr. Salfa doesn't mention to you, the price of the HIFU machine is expensive. Yeah. And then I think that's the most winning point for the vaginal myomectomy for the compared to HIFU fibroids. But in terms of intramural, I do have to agree. I'm a gentleman, Dr. Salfa, so I agree with you. Intramural HIFU will be more benefit. But of course, to be able to perform HIFU, you must purchase the machine, which as for now, I cannot afford it. So what I'm offering you is to do the vaginal myomectomy, especially for the serous type. It will be best. Thank you.
Thank you, Dr. Selva. You also get 1 more minute to say.
Okay. I will not disagree that
machine versus difficult surgery. That is what the audience, you have to vote. Both modalities are new. Both are very good, but expense versus difficult surgery. So be ready to vote yourself, audience.
Okay, why I totally agree. The machine is not cheap; it's expensive, but it's because it's new. So we hope that in time to come, the price will come down, and more people will be able to do it. The biggest advantage of HIFU is that any one of you who are doing ultrasound can do it. Okay, that means you just go for training, you come back, you can do it. So you can pool the data, you can pool together. Say in one city, Mumbai, you just have one machine. Everybody pool together, buy one machine, and everybody use it. You can do it. I mean, Mumbai has got 20 million population, and there are probably hundreds of thousands of gynecologists. Each one just come up with a little bit of money and pool and do together. And I think you can do that. You see, so cost is a problem. I agree with you, but it is if you are convinced that it is going to benefit the patient. It's not all patients, but in certain patients, especially people who keep coming back for myomectomies, small fibroids where you don't want to do surgery. These are very good indications for patients to do HIFU. So cost is a factor, but if you have the will, you can pull together and get one machine. I'm sure Nandi can do that.
If you have the will, you can get the machine. And cost, both of them agree on one point each. He agrees cost is a factor, and he agrees intramural fibroid, I cannot take them out vaginally. Dr. P K Shah, your comments.
I think we have seen after a long time a debate where both the sides were honest. So we have honest doctors from Indonesia and Malaysia, telling us the facts and not trying to push us into any one of the topics or techniques. Dr. Nandi very nicely with pictorial diagrams showed us how easily you can remove the myoma. It was so easy when he showed it. But I know we all Indians are more into vaginal surgery and one has to learn. Even if you are a good vaginal surgeon, whenever a new technique comes related to vagina, you must learn first, then it becomes very easy. But as he very rightly said, that is very easy to learn, easy to perform, quite ergonomic, and it's hardly any complication that you can think of. So in that sense, I think he was very right. At the same time, when you talk about high intensity focused ultrasound, we were told very nicely the differentiating characteristics of MRI guided and ultrasound guided HIFU. And I know all of us definitely would prefer ultrasound guided HIFU. It's very simple comparatively. And it's not question of Mumbai or India. I think we have to offer options to the patient and let her decide what she wants. She wants removal of the myoma or she wants reduction in size so that symptomatically she can improve. So I think once you give all these options to her, let her decide exactly what she wants. We must have in our basket all these options available. I think a fantastic talk by both of them. And I would like all the viewers who are watching to give them a big round of applause. And I must thank not only Dr. Narendra, because he is a good umpire. And we don't have a third umpire, so we have to decide between two of us only. And what is important is every time we are called to do this umpiring, it is the BCCI chairman, Dr. Niranjan, who does this job of appointing two umpires, Narendra and myself. Because of
it's
COVID,
honorary job. You're not getting paid for it.
Yeah, we are doing totally honorary job. And I could not join some of the endoscopic premier leagues because of COVID infection. But after joining, I think I'm enjoying it much more. And thank you very much, Dr. Niranjan Chavan, for arranging such fantastic webinars, which are really good. People enjoy it. There is no heavy stuff going into their minds. It's taken in a very light note. At the same time, they are learning. Thank you so much, all of you.
So I am getting a lot of results and they are pouring in the votes and I'm just totaling them and we'll get back to you after Dr. Niranjan reads some comments. One of the comment which from Dr. Lee from Singapore, I love the cowboy hats of the umpires.
Well, thank you. Thank you, the great umpires today. Well, I'm going to talk a little bit with an accent today. We have friends from Malaysia and Indonesia. And I want to read the comment from Dr. Lee Kin Wai. And he has said that there are many Singaporeans who are watching this match today. And I love the way Dr. Ichnandy talks. But Dr. Ichnandy, it's a misnomer to call single port or vaginal approach no scar. There are scars, but not visible or hidden scars. It's best to be more correct to inform patients that technology has invisible or hidden scars. So this brownie points goes to Dr. Sevellaraja Supermaniam. Well, there is comments from many other Indians today and Dr. Geeta Shevgan from Aurangabad. This is a comment, and she has appreciated Dr. Selva's wonderful video and the presentation he has done. And it's very important to avoid the complications. So she has asked you how you can avoid these complications, which are there 0.1%.
0.6.
Selva.
I mean, if you say that you never had any complications, even when you do surgery, that is not possible. So I think we cannot avoid complications, but we can select patients well. I mean, as I say, I have not started doing HIFU. Dr. Lee Kin Wai is the one doing HIFU. I've only went for training, and I'm going to start. From what I know is that if there is any suspicion of a bowel that is near or in the area of the fibroid, then you've got to be very careful. So that is the only way to avoid. And I think even in this series, it's done by experts. 2 in 10,000, I think, is very, very rare. I mean, hardly any. So I think accept that. We can accept that. If you want to have 0 in 100,000, I think that is not
possible.
Never possible. So there are techniques that we will do to prevent it. For example, we need to prepare the bowel. We need to bring the bowel away. There are a lot of things that we do when HIFU is done. So HIFU is just not shining beam. There's a lot of procedures, a lot of learning things, a lot of technology that you need to do before you can do it. How to shine the beam, what dosage to give, how deep to give it. So there are a lot to learn. It's not as simple as what we think. And also just like when we started doing laparoscopic surgery, we started doing with small fibroids, then we move on to bigger and bigger fibroids. Similarly, we will start with simple cases, and then we move on to more and more difficult cases.
Thank you. Any more comments, Dr.
Sir, there are many comments here. Answer, Dr. Narendra Malhotra, the results are to be announced, but we have to wait because the results, there are votes being pouring in. So just wait, sir. And this is Dr. Meera from Varanasi. Varanasi is a holy place in northern India where we meet the Ganges, Yamuna, and Saraswati, where we meet at Allahabad. Varanasi is also the seat of our Prime Minister Narendra Modi, and we have Dr. Meera there telling, excellent program, not for the sake of just telling, but I loved each and every episode of Endoscopy Premier League. TOG EPL rocks. Dr. Pawan Dheer from Ahmedabad. This is again the capital where our Modi Honorable Prime Minister has come. And he says, fertility after HIFU. This question is for Dr. Selva. What do you feel about the fertility after HIFU?
He has already answered that in the talk. But
I'll answer again because just now
I
was rushing through just now.
Yeah,
yes, fertility is my concern. I'm also an IVF specialist. Fertility is my concern. The big advantage of HIFU is that it will not reduce the ovarian function. Ovarian reserve is not affected because we are focusing on the fibroid and nothing to do with the ovaries. As opposed to uterine artery embolization, there's always a worry that there is a reduction in ovarian reserve. So you don't have to worry about ovarian reserve. Fertility outcome is the same as the patient before HIFU treatment. But to add on to it, I am more interested in this machine because I have, just like all of you all, have a lot of patients with adenomyosis who want to get pregnant, and we don't know what to do with them. I mean, you can do an adenomyomectomy. It's a horrible surgery. I hate to do it because you don't know what you're doing. You don't know how much you're cutting. But this is an opportunity to ablate the adenomyosis, shrink the uterus, and hopefully the patient can of course reduce reduction in symptoms and pregnancy. So this is the area of my interest when doing HIFU.
Thank you, Dr. Silva, bringing up adenomyomas and adenomyomectomy for HIFU. HIFU would be absolutely ideal treatment for adenomyosis. Dr. Niranjan, any more comments?
Yes, sir. This is a comment from Safog, Dr. Haldar from Nepal. Excellent umpiring and post-session comments. 2 good speakers. The speakers were very good. Dr. Nandi from Indonesia excellent videos which you have showed of myomectomy and the procedure how you do. We are all eager to see you in person when the corona opens. And thanks to TOG EPL and Dr. Niranjan to bring a fantastic doctors to India. This is Dr. Haldar from Nepal. Dr. Pavandir again, he is telling that Dr. Selva, you are doing a wonderful job. Dr. Pavandir from Ahmedabad. This is Dr. Ungai, Nairobi. We are having from Africa members, doctors, super talk by both the speakers. Dr. Kanya Menon from Koida Canal. High voltage drama. Oh my God. Well, thank you. Thank you. These are the wonderful comments. They are still coming. And I request Dr. Narendra Malhotra to announce the results.
So we have finished well in time of our this grand finale of IPL with excellent teams, excellent talks, excellent points put, which are almost same. Now in India, I don't think anybody is doing a vaginal myomectomy like this. They are doing vaginal, they put in a morcellator, and I saw that Dr. Kiran Kohle do one yesterday on the Facebook. She put in a video, and I think there is only one or maybe two machines of HIFU which are MRI guided. And we do need an ultrasound guided because we are very good at ultrasound. And we are very good at vaginal surgery in India. So these two modalities will fit into India very beautifully and very nicely. And Indians are going to adapt to this very nicely because they don't want scars and they want fertility to be saved. And we don't want to cut the uterus to remove 2 to 3 centimeters intramural fibroids. So it's a tie. It's actually a tie, 51-49.
Oh. Do we have a Super Bowl? Do we have a Super Bowl?
51-49 I consider is a tie. So Indians want vaginal myomectomy and Indians want HIFU. And fantastically well done, very well explained and very well shown. Over to you, Niranjan, to close the match.
Absolutely, that showcases the full packed stadium. The full stadium is full packed. It's 1,978 doctors which have logged in. And we have a good comment here from Dr. Pratap Kumar from Manipal.
Yeah.
Yes, Dr. Selva and Dr. Nandi, nice talk. It's nice to catch up with you guys. This is Dr. Sulabha Joshi from Nagpur. Nagpur is in the central India, and right now we have just started the cold wave. It appears about the uterine bleeding pain, etc. will take long time to get relief. Dr. Selva, does it appear about the uterine pain and the bleeding which is there? Is it going to take long time? That's what she asked you, Dr. Selva.
The answer to the question is the bleeding, as I said, this is an ablative therapy. It will not, there is not immediate as opposed to myomectomy. It will take some time, but from the experience, within 2 to 3 months, the bleeding will be reduced. This is for fibroid. Pain, there's no pain, as opposed to uterine artery embolization, where it is shown that there's a lot of pain after the procedure. UAE is not, because we are ablating and killing the fibroid, not shrinking its blood supply. That's the difference.
Thank you.
Thank you so much. And we have got now many comments, and they want to learn vaginal myomectomy. Dr. Nandi, you have to come to India, virtually probably. And Dr. Selva, they want to see HIFU with you doing at the hands-on, along with Narendra Malhotra and Dr. P K Shah, the pioneers of ultrasound. So we are going to have a wonderful, probably a course coming in future, and we will line up all those wonderful things on vaginal myomectomy on one side, with our colleagues from Jakarta, Indonesia, Singapore, and Dr. Selva, along with our ultrasonologist and MRI specialist from India, Dr. Narendra Malhotra, Dr. P K Shah. Dr. P K Shah, I can see your hand raising, but just before that, I want to just one or two comments. This is Dr. Hari Prakash from Karnataka. Sir, please bring them to India. Yes, Narendra Malhotra, sir. We are all waiting for that big thing to come. Dr. Sneha Chavan, sir, I'm a student, but will I want to join the course? First to join. Oh, already we have got a one student already asking to join the course. My God, I can't believe this. This wouldn't
Nandi
have
has
been
an
such a
online
hit.
course. Nandi has an online course. Go
Yes.
to his website and see the notes, vaginal notes.
Yeah, he said that.
Wonderful, wonderful. This is Dr. G. Manasa Vishakhapatnam. Excellent talks by both the doctors. And I ask Dr. P K Shah sir to please go ahead.
I think Dr. Selva, we visited Malacca when Dr. Pratap Kumar was the head of the department.
I was
That was long back.
I was one of the organizing chairman. Yeah.
Yes, I
Yes,
think
he was,
I
he
met
was
you
very
at
much
that
there
time.
and we had such a great time.
Yeah. We met you at that time. It was a conference which was organized, and that was the time when I saw you first. So I was thinking all the time, and once the name of Malacca came, I realized immediately. Nice meeting you, and we will meet in person somewhere, at least not outside India, in India at least, maybe next year.
We will.
Nandi, both of you will come together so that people will remember that you fought in front of them, and then
We are
as
a good friends. We cannot sport.
and as friends, you will teach them together. So nice, very nice.
Thank you so much. Thank you, both of you, joining live. And thank you, the umpires, Dr. Narendra Malhotra, sir, Dr. P K Shah, sir. This whole EPL series wouldn't have been possible if you wouldn't have been there. And the way you have umpired, and of course, Dr. Pavandeep, who also joined, and it was amazing to see those wonderful pictures and the way you have conducted, sir. It has become a hit in India. EPL is synonym to IPL, and I thank both of you. Amazing. And this showcases that's what we have today, maximum questions across India. And this surely was too good. The contributions which the speakers have given, fantastic. Thank you so much. And we will catch up next year, 2021 EPL, or probably a Gynac Premier League coming up with a much wonderful time. Thank you so much.
Bye.
Bye. Have a good night, everybody.
Good night.
Good night.
Happy Deepavali.
Yes.
Yeah, all of you have.
Happy Deepavali.
Happy
Happy Deepavali.
Happy Deepavali.